Hello friends, this is from Chambers and today we'll be discussing the factors which are determining the cardiac output. In the past video we have talked about the cardiac output measurements and we said cardiac output, the formula for cardiac output is CO is equal to stroke volume into heart rate. Okay. And we said what is cardiac output if you want to speak in a subjective manner, that in your body with each beat certain amount of blood is pumped out by each ventricle into the circulation. That certain amount of blood which is pumped out by each ventricle, that means we have two ventricles, so I am talking about one ventricle, by each ventricle into the circulation will be called cardiac output. And we said there are two terminologies which were affiliated to this cardiac output. We said one is stroke volume, okay, and we said stroke volume and minute volume, isn't it? Minute output. So stroke volume means what? Stroke volume means the amount, the output per ventricle per beat, isn't it? So stroke volume is equal to output per ventricle per beat, isn't it? I hope the sound is clear. Okay, I hope the sound is clear. Okay, now clear sound. Okay, so what does the minute volume become? Then minute volume should become, minute volume is equal to stroke volume into heart rate, stroke volume into heart rate, stroke volume into heart rate, isn't it? Minute volume, how much volume is being ejected, that minute volume. Okay, now you had a question last time, sir, what is the amount of blood being pumped by the right ventricle? What is the amount of blood being pumped by the left ventricle? So if I take two ventricles, and you were asking, sir, what is the amount of blood pumped by right ventricle? What is the amount of blood pumped by left ventricle? Right ventricle is equal to left ventricle in blood pumping. Okay, so same volume of blood is being pushed out from the heart. Therefore, can I say, if you want to measure the cardiac output, if you want to measure the whole cardiac output, I will ask you, what is the cardiac output of the heart? So can I take it as twice RV or twice LV? Because cardiac output, the definition is with each beat, what is the amount of blood being pumped by each ventricle into the circulation. So that means if I say what is the whole output of the heart as a whole, if I take the heart, so you will say, sir, I will multiply, do the twice of one ventricle, and that will give us the whole heart, because ventricle are the ejection pumps who are circulating the blood throughout the body, be it lungs, be it systemic circulation. Okay, and we also said in the last lectures that the stroke volume is equal to 70 ml. And what is the minute volume? Minute volume is equal to 5 to 6 liters. That's what amount of blood you are seeing is being thrown out per minute. Okay, is it clear? Okay, so what is the distribution of blood? What is the output which you have thrown out? What is the distribution, where it is going? Now you tell me, whatever blood is coming to the heart, so whatever cardiac output you are throwing out, should it be equal to the venous return? Whatever amount of blood is coming to me, that I should throw out. So that means whatever the cardiac output is, it will be determined by the preload or the venous return. So how much amount of blood is coming into the ventricle will be finally determining the cardiac output. That means whatever the minute output you want, the venous return per minute should be same. The venous return per minute should be same. Are we clear with this concept? We should have the answers from the people. Okay, fine. That means if 5 liters of blood is coming out per ventricle per minute, if 5 liter of blood is coming out per ventricle from the per ventricle per minute, that means 5 liter of blood is flowing through the tissues per minute. That means same 5 liters is coming back to the heart per minute. Is it clear, friends? So whatever amount of blood you are distributing, that should be coming back. So in other words, I can say 5 liters of blood coming out of the ventricle per minute. 5 liter of the blood, which means 5 liter of the blood is flowing through the tissues. Okay, so because we have all these system connected, this is my tissue. Okay, I should make a circuit for you because some people are lost. So this is the aorta and this is going to the systemic circulation. And then it's connected to the right atrium, isn't it? Right atrium. Okay. So guys, these are the 4 chambers. I'm not wasting time in making the diagram. Okay. So what is happening is I am saying 5 liter of blood is passing out from the ventricle. Okay, sir, 5 liter of the blood. That 5 liter of blood is per minute. Please remember per minute. That 5 liter of blood will be flowing through the tissue. 5 liter. And that 5 liter should come into the heart, venous return per minute. Okay. So, it's not something that, we may be having a question that how this is, how accurately these things are happening with time, quantity. I will be teaching you the auto regulation also. Okay. That is a different topic. Yeah, exactly. Yes, that will be equal to the venous return. Yeah, exactly. Okay. So, there is some data in the books that you may come across that what is the amount of blood being sent to the muscle, what is the amount of blood being sent to the liver, what is the amount of blood being sent to brain per minute. So I will write that, approximate. Okay, I will write that as an approximate idea. So let us write. So if I talk about kidneys are receiving approximately 1300 ml of blood per minute. Okay, they are receiving 1300 ml of blood per minute. I should not draw it from this side. Okay, so this is the amount of blood. Next, I should say about next organ which is receiving its brain. Okay, brain receives at 700 to 800 ml per minute. Okay, amount of blood being sent to the heart, coronary circulation. Heart has its own circulation, isn't it? I hope you know this from the histology. Okay, so coronary circulation. So coronary circulation will be receiving how much? 200 ml per minute. What about the muscle? Muscles receive how much? 600 to 900 ml per minute. Okay, and liver how much? Approximately, I think 1500 ml per minute. Okay, this is the amount of blood being received by the organs. Okay, so sir, it's around the total what you have done. Maybe it's around 4500. I think it's not 5 liters. So where is the rest of the blood? It's going to some other organs, skin, GIT, bones. Okay, are we clear? Now, this was about this volume. I distributed this volume for you so that you can understand what is happening. Okay. Now, see, again, I take this equation. I take this equation of cardiac output. See, guys, before understanding this cardiac output, I should understand what factors will be doing something with this stroke volume. What factors are doing something with the heart rate? What factors are regulating the heart rate? That will also determine the cardiac output. What factors are affecting the stroke volume, that should also determine the cardiac output, isn't it, guys? So that means it's important to understand what? It's important to understand these quantities. Okay, the multiplication of these quantities is giving you the cardiac output. So that means I should understand stroke volume. No, nicely, what factors will be doing. So let us take the first. Let us take the stroke volume. Understand it. Okay. So let me take the stroke volume. In the past videos, we have discussed every definition. I don't have to explain those. That's why I give you those tools in the beginning so that you become, familiar with these terms. Okay. Now it's easy for you to. Okay. So I will say cardiac output is equal to stroke volume into heart rate. Now I will be explaining the stroke volume. Now, what factors affect the stroke volume? What factors affect the stroke volume? Now, different books will be writing different things. Some are writing 4, some are writing 3. Okay, so I would go for 3. Okay, I would go for 3 major factors. So let me take the stroke volume. Okay, now this stroke volume is determined by 3 factors. Every time you write anything about stroke volume, 3 things should come into your brain. What things? 3 things. Cap. What, guys? What should come into your brain when you think about stroke? Stroke in the cricket match. Stroke is cap. What, guys? Cap. So open your 3 fingers. Open your 3 fingers. Have you opened? So open consecutively, okay? So number 1 C is contractility. Number 2 is afterload. Number 3 is preload. What, guys? Contractility, afterload, preload. Okay. So contractility, afterload, preload. This cap should be remembered. So stroke volume is determined by 3 major factors: contractility, afterload, preload. Okay. So who will determine the stroke volume? Contractility. Who will determine the stroke volume? Afterload. Who will determine the stroke volume? Preload. So these 3 should be remembered. Cap is determining the stroke volume. That means I should have adequate knowledge of preload also. So I should take the preload then. Let me take the preload so that I can make it, you can understanding much better. So let me take the preload. See, guys, I taught you in the last discussion, to make it summarize it again here. I said preload is equal to, we think, because preload is the amount of blood. Preload is the amount of blood that is present in that relaxed ventricle. What is preload? It is that degree of tension or that degree of load which is present on a ventricular muscle which has achieved its highest ventricular relaxation state, or when it is just beginning to contract, isn't it? So this is the ventricle. You have reached the end of diastole. You have reached the end of diastole. Can we understand the end of diastole? Diastole means relaxation. So I have reached into the end of, I have reached to the end of diastole. So very nice. So when the ventricle is about to begin that contraction, just before that, the load, the tension, the degree of load, the degree of tension which is present on the ventricular muscle when it is beginning to contract is called a preload. So that means I can say in my layman language, to make myself understand, that it is that amount of blood against which I have to contract in the ventricle which is present. In the ventricle, what amount I have, that I will be ejecting out. But whatever is the status of the vessels outside, whatever is the status of the total peripheral resistance, that will be determining the afterload. So that means that column of blood against which I have to contract. Which blood? Which is present in the aorta, which is present in the arteries, systemic arteries. Are we clear? We have taught you everything about this, I hope. Okay, so no need to make it more, I'm just recapping it. Okay, so this ventricle in the relaxed state, whatever is the amount of blood present here, whatever is the amount of blood present here, what is the amount of blood present here, that will be the preload in the relaxed state. So I can also say it's just starting to contract, the amount of blood which is present here, and that blood is putting some tension, that blood is putting some load. So the degree of that blood, that will be called as the preload. So that means this blood should be the end diastolic volume, EDV. This should be the EDV, because EDV is the amount of blood which is present in the ventricle at the end of diastole, which is itself dependent on the venous return. Whatever you give me, I will become the EDV. Whatever you are giving me, filling me till the contraction starts, I will become the preload. Whatever you bring inside me, I will become the preload. That will be the preload, isn't it? So if you are bringing more amount of blood to me, that means you are increasing the end diastolic volume. That means you are increasing the preload. That means I have to work that much to eject that amount of blood from the heart chambers. Are we clear? So it became a relation, sir. Sir, it became a relation. If we want to make it easy, we will say preload. Preload is determined by EDV. Preload is determined by EDV. EDV is itself determined by venous return. Is this chart clear? This is the simple arrow which you can understand, isn't it? So whatever is the preload, that is being determined by the EDV. That's why we call it synonymously. We say preload is equal to EDV. We say preload is equal to EDV. Fine. That means this increased EDV will actually cause an increased stroke volume, isn't it? That EDV will cause an increased stroke volume. Okay. Now, why, sir? This is why. What is the concept behind this? That you are saying EDV will increase the stroke volume. If you ask me, I would say there are so many things. So the physiologists are discussing about this. Okay. So, but they have put forward, a thing which is being followed. There are two theories. Which make us understand this concept that EDV increases the stroke volume. EDV increases the stroke volume. Okay. So first theory is frank-starling relationship. Frank-starling relationship. Frank-starling relationship. This frank-starling relationship is also known as ACA. It is ACA. ACA is length tension relationship of the heart theory. What is the theory called? Length tension relationship of the heart theory. Length tension relationship of the heart theory. So one is this, another is contractile apparatus theory. That is contractile apparatus theory. One is this, another is, it's not, I've just made easy for you. The name is not, the theory is not like that. The theory is saying that the cardiac myocytes, they become more sensitive to cytoplasmic calcium. Okay, so you can remember in short by cardiac contractile apparatus. Cardiac contractile apparatus. Okay, so what is the concept of frank-starling relationship? Making it so easy, I'll make it easy. No, okay. So frank-starling relationship, it says if you increase the ventricular wall tension, if you increase the ventricular wall tension, can you understand the tension? Think something that something is pushing the walls. And you know, heart myocyte, they are all contractile in nature. I hope you know that, isn't it? The myocytes we have discussed in histology. Okay. Now think, it is saying, first I let me speak about the theory and then we make it applicable. So it is saying that if you increase the ventricular wall tension, let me take this theory. It says if you increase the ventricular wall tension, if you increase the ventricular wall, it's the ventricular wall, okay? I'm taking the right side of the heart. If you increase the ventricular wall tension, this end diastolic volume, isn't it? Should I call it end diastolic volume or not? This end diastolic volume is producing some tension. That tension is associated with what they will cause. They will cause more stretching of the ventricular myocytes. That means when you stretch the ventricular myocytes, that means you are making more actin myosin filament cross linkages. That means you are making more overlaps of actin and myosin. I hope you remember that basic concepts of physiology I taught you. Muscle, physiology of muscle. So you are making more amounts of actin myosin overlap like this. You are making more amounts of actin myosin overlaps. If you are increasing the number of overlapping, please listen to my word. If you increase the chances of overlapping of actin and myosin filaments, you will be increasing the more force because the contractile force will increase. Once you increase that force, you will increase the stroke volume. Whatever stretch you produce in that, you will be increasing the stroke volume, isn't it? So there will be more amount of cross-linking, isn't it? Cross-linking like this cardiac myocytes. They will cross-link. Once you produce more force on them, what will happen? The force of contraction will increase. They will come like force of contraction. And that force will eject this more amount of stroke volume. Are we clear with this concept? Are we clear? So what is the theory saying? That end diastolic volume is producing a stretch on the ventricular myocytes, leading to the point is this greater overlap of actin and myosin filaments. Are we clear, guys? This is so important that it's easy to understand. Even it's easy to understand and important too. Okay, that means if I ask you, if I increase the overlap, I will be producing dash. If I increase the overlap, I will produce dash. Increase the overlap and I will produce dash. Beautiful answer. Will produce force of attraction. That means what in the end? That means in the end what? Yeah. In the end what? Yeah, more force. That means the end dash. Force is equal to contractility. Exactly. Beautiful answer. We will be increasing the stroke volume. This is the concept we have to remember. You increase the overlap, you will produce more stroke volume. Are we clear, guys? Okay. Because I have to say, are we clear? Because it's important concept. More about conceptual. Okay. Now, is the recording happening? Yeah, recording is happening. Okay. Now see, second theory I was talking something about that cardiac contractile apparatus business. Okay. This business is saying you have a contractile apparatus, isn't it? You have that contractile apparatus in your myocyte. It is saying if you are increasing the preload, listen to my words, I will write that. It is saying if you increase the preload, again I take this diagram. It is saying if you increase the preload, see preload is increasing because the diastolic and diastolic volume is determining this preload. It says this preload does some changes. It is saying this preload does some changes in the cardiac myocyte apparatus. What changes, sir? It makes the cardiac myocyte more sensitive to calcium. cytoplasmic calcium. Now you tell me, isn't the calcium responsible for the contraction, troponin C, trop C? Do we remember that in the cardiac, in the skeletal muscle? So once you increase more calcium, you will be increasing more contraction, isn't it? So what that this theory is saying, it is saying the cardiac contractile apparatus of cardiac myocyte is becoming more sensitive to calcium when you are increasing the stretch. Which stretch? It is being produced by the preload. So whenever you increase the stretch, to make it easy, when you increase the stretch, what does it mean? I am increasing the preload. So I should write like this. I should write it right like this in the reverse. So if I increase the preload, I will increase the stretch. If I increase the stretch, I increase the sensitivity of contractile apparatus. Contractile apparatus of what? Cardiac myocyte. If I increase the sensitivity of cardiac apparatus to what? To, this is important. This is important. Calcium. Calcium. Which calcium? Cytoplasmic calcium. So if I do this, I will be increasing the sensitivity to cytoplasmic calcium. Why? Because you produce a stretch. By which you produce the stretch, the increased preload. Are we clear? Is this concept clear? Okay. So this is the frank-starling. These are the two theories which are actually supporting this, business of cardiac output. Okay. Now see, guys. Can I say the preload is affecting the heart performance? Okay. So you can take the video back. Okay. So because the video will become, if I start explaining it again and again, you have to watch the video. Okay. So can I say preload is affecting your performance? Can I say the preload is affecting the performance? Yes, sir. So can I say preload affects the cardiac performance? Preload is affecting the cardiac performance. Okay. Some books may be writing, they write two terminologies. I want to say that also. They say the factors which affect the SV, they divide those factors into two ways. Okay, remember from this. One is heterometric regulation. Okay, let me make it for you. So they say, we wrote about stroke volume. It is being done by CAP, isn't it? CAP. So what they do? They have done, they have classified it. They say the factors which are affecting the stroke volume, they have divided them into two categories. One is heterometric what? Regulation. Heterometric regulation. Another is homocentric regulation. So heterocentric regulation, homocentric regulation. Heterometric regulation says, remember just one thing about this heterometric. The things which will change the length of myocardium. Once you are filling this myocardium, for example, this was the myocardium, this was an empty myocardium. But if I fill it, what will this myocardium become? You will increase the length, isn't it? Once you are filling it with blood, preload, what will happen? You will increase its length. So those factors which are changing the initial length of myocardium, those factors will be called heterometric regulators or heterometric factors. Can I say preload is a heterometric regulator? Can I say preload is in this category? preload. We are not getting maximum answers from the students. I think they are sleeping in coronavirus, isn't it? So heterometric regulation, isn't it? Heterometric, can I say? Okay. So this is here. Sir, what about homocentric? This I will speak in the, the next topic. Okay. So I'm just making it interrelated, okay, to understand things. So preload, everything about the preload. Heterometric, you should remember at least that preload is doing that. Heterometric regulation. It is doing that. Heterometric regulation. Okay. So there is a concept that what is the initial length? What we are saying, what is initial length? What do we mean by initial length? What do we mean by the initial length of muscle fiber? See, initial length of the muscle fiber means uh, the length which is just before the systole. The length which is just before the systole. Length just before the systole will be called the initial length. Very nice. Will be called the initial length. So that means that length will depend on the stretch, whatever stretch you are producing at the end of diastole, isn't it? That means this length will depend on the stretch. So that's why I use that word. Okay. So that can I say end diastolic filling and diastolic filling will determine the initial length. Can I say and diastolic? See, everything is related. Whatever we have learned, we are connecting it in many ways. It's all about the concept. I hope you are understanding. There is no difficulty in understanding this. So if I increase the ventricular filling, that means I will be increasing the fiber length. That means I will be increasing the force of contraction. That is what heterometric autoregulation says. Okay, so stroke volume will vary according to that ventricular muscle length. That is what heterometric autoregulation says. Heterometric autoregulation. Can I say heart is having its own autoregulation? You are regulating the output. Why? Because you are making the heart accountable for all that is happening. Whatever stretch you are producing, whatever end-diastolic filling you are doing, that is actually determining the stroke volume. Okay. Now this end-diastolic filling will itself depend on many factors. Can I say end-diastolic filling will depend on the venous return? Can I say it depends on the atrial pump activity, whatever atria has thrown down, whatever the atria has thrown down, whatever blood the atria has thrown down in the S4, isn't it? Can I say it's about the atrial pump activity? Or can I use the ventricular compliance? Compliance means stretchability. Can I say the ventricular compliance? Compliance of the ventricle. How much the ventricle was able to contract. It's not, for example, if I have a systemic sclerosis, a disease in which the ventricle is itself not able to get relaxed, it's not able to get stretched. So the disease lies in the ventricular myocardium. So that means these will be determining the end diastolic filling. So whatever is the venous return, that will determine the end diastolic filling of the ventricle. Whatever the atrial pump activity has happened, that will determine the the end diastolic filling, and whatever is the ventricular compliance, how much this ventricle can stretch, will also determine the end diastolic filling. That much blood will fill into the ventricle. Are we clear, guys? So if I talk about this venous return, okay, let me connect it here only. Let me connect it. Okay, we will enjoy it. I think we enjoy it once we connect everything. See, venous return. What is venous return? Venous return is the amount of blood that is returning to the right atrium. From where? From your all the venous circulation. That means I should say the systemic venous circulation. So venous return is the amount of blood that is returning to the right atrium from the systemic venous circulation. So if this is your systemic venous circulation, this was the arterial circulation, okay, all the branches, okay. Now they have supplied the tissues, and now from these tissues they will be coming back through the They will be coming back. I should make a common vein for them. So they will be coming back, joining through a common vessel, and then draining to me in the right atrium. Draining to me in the right atrium. I have taught you. So this return, whatever return is coming from all the body cells. This I'm representing this chart as a body. So whatever blood is coming into the right atrium from the systemic, listen to my words, systemic venous circulation, that will be called the venous return. That venous return. Now tell me one thing, guys. If you know there are so many pumps there, it's not only that heart is a pump. There are other pumps also in your body. Like you have, let me write some pumps. Muscle pump. You have muscle pump. You have skeletal, I should write skeletal muscle pump. You have thoracic pump. Thoracic pump. What else pump we have? Abdominal pump. Abdominal pump. We have sympathetic activity. Sympathetic activity is actually doing everything. Sympathetic activity. Sympathetic activity. And your extracellular fluid volume. Or the extracellular fluid volume. That is the amount of blood, that is the volume status of your extracellular fluid which is present in the vessels. Now, what is this skeletal muscle pump? If I take it, what is skeletal muscle pump, guys? This skeletal muscle pump, for example, if I take your muscles of your lower limbs, for example, you have that calf muscles, isn't it? So, the beautiful thing about the human body is that the God has constructed the body in such a way so that your all veins, they are surrounded by the vessels, the muscles, skeletal muscles. So your majority in your body, the veins are surrounded by skeletal muscles. This is first concept you have to remember. Then you can understand the muscle pump. If I make a diagram for you guys, so if I take this as a blood vessel, and around this blood vessel, I am making the lower limb muscle. Okay, lower limb muscle I am making. Let me make the muscle with sparkle color. If I make a muscle like this, we should understand in a crystal clear manner. Open the things and see what is happening. Then only we can understand the disease part. Now this is my vein. This is the vein. This is the vein. Okay, this is the vein. And surrounding this vein, I hope you know veins have valves. Veins have valves so that the blood can reach, so that the backflow is prevented, isn't it? Because veins are bringing the venous return into the heart, into the right atrium. This I hope you know this. Okay, so we have valves at many moments like this. We have valves. Okay, fine. This is also clear with you. We are going into elementary because this is a first year class. Okay, that's why I'm talking so elementary. Now, guys, once you do contraction of lower limb, what will happen? This will actually, what will happen is, yeah, what will happen? Once your limb veins, now first you have to tell me, are these valves opening towards the heart or away from the heart? Are these valves towards the heart or away from the heart? They open towards the heart. They open towards the heart. Okay, this is first concept you have to remember. They open towards the heart. The valves open towards the heart. Once you do the contraction of the skeletal muscle, what will happen that this will compress the veins and push all the blood towards the heart. Push all the blood towards the heart. What will happen finally is the venous return will increase. What will happen is the backflow of blood will be prevented by those valves. So all the blood will be pushed, whatever is present, whatever amount of blood is present here, that will be pushed into the towards the heart. That means the venous return will increase. So you are running, you are walking, you are doing any strenuous muscle activity, your cardiac output will increase. The reason is that you are increasing the venous return. You are increasing the venous return, that means you are increasing the preload. That is, you are increasing the end diastolic volume. That is, you are increasing finally the stroke volume. Is it clear? But if I am standing, now I am standing on the, this is me, okay? This is me, poor guy. And I am standing. I think I have rickets in this. No, no rickets. I am standing. I am standing. So I am standing and I am standing, okay, standing. I think I have some sort of a lower segment disorder, okay, pediatrics. Now what will happen is, due to the gravity, the blood will gravitate. The blood will gravitate in my legs. It will gravitate. This is called pooling of blood. Peripheral pooling will happen. Peripheral pooling of blood happens. Peripheral pooling of blood happens. Once I'm standing, peripheral pooling of blood will occur. And since you are not contracting your muscle, same thing, you are not contracting, I am sitting still. What will happen? My venous return will decrease. That will decrease dash. That will finally decrease dash. Finally, go to the extreme end of your brain. That will finally decrease the dash. Very nice answer. That will decrease the stroke volume or the cardiac output. So this pooling of blood, increased pooling of blood leads to decreased stroke volume. So can we understand how body is regulating that when I am not in need of much blood, this is actually making the homeostasis. This is actually maintaining the homeostasis of the body. That once when in times of that surge of that blood, I need that blood very badly. Once I'm running, I'm going away from the dog. What I need more amount of blood. That means my muscles should pump in such a nice and orchestrated manner that the blood is being constantly pushed into the right atrium, and that is increasing the stroke volume. But once I am quietly standing, I'm not doing anything. That means I don't need any blood. Why will I get the high stroke volume? Except if it is a disease. Okay, so I don't need any stroke volume. So that's why the cardiac output will decrease. Okay, now you may have come across that once you are standing, you were in the school, you were standing in the prayer, and you were asking God about the marks distinction, isn't it? Nothing else. You did not ask God about to become a nice person. You just asked about becoming getting marks, isn't it? You did not ask him for becoming a social worker, isn't it? So what you were doing is, all are standing, and suddenly what happens in the morning assembly, and you were also asking something else. Okay, maybe, okay, that I can't speak here. Now you may be asking something else also. Okay, looking by your side. Okay, now see what will happen. What happens suddenly? A person collapses. A person collapses at your back. You were in the assembly for some 1 hour or something. What will happen? You will faint. You are seeing somebody has fainted. What happens? Basically, what happened due to that prolonged standing? What happened? The cardiac output decreased to a greater extent. The cardiac output decreased to a greater extent. Greater extent, and that was not able to give that adequate supply to your brain. That's why the person fainted. That's why once we see anyone, what we do. So what happens? See, it happened last time. In my medical school first year, I was able to save a student, my classmate. What happened that we were doing? Basically, it was a physiology practical, and after standing in the laboratory for at least 2.5 hours, we were working continuously. We did not sit. We're working, we did not walk in. We were standing at one side and doing all those blood analysis and everything. So what happened? Suddenly a girl collapsed, fainted. So what happens? You should not panic. Everyone starts doing something, beating their thorax, somebody beating his head. What happened? Oh my God, our friends, something, getting water. What will water do? Nothing. What you do is, you put that person, what you do once she faints, just try to increase the venous return. In 1 minute, she will wake up by auto-regulation. and she woke up. That's what I trust on my medicine. Okay, she woke up. Okay, so she had lost her consciousness. In 1 minute, she regained the consciousness. Okay, so that's what we do. We can also do the elevation of the limb movements. You can elevate the limb. Once you elevate the limb, what will happen? Blood will return more towards the heart. What a beautiful concept. And that's what happens also on the roads, that the people who are police personnel who are working so hard to very nice people, salute to these people also, who are maintaining the traffic flow so that ambulances can reach, the patient can reach the hospital. So many things they do. No, very nice people. So they are maintaining the traffic flow. What happens for long time standing? What suddenly if they collapse, what will happen? You should do the limb movements to save him. Okay, so you should do that thing. Increase the venous return in some way. Are we clear? I have connected everything with this venous return. Okay, this muscle pump I have connected. Okay, so next pump, what was the next pump? Next pump was thoracic pump. Next pump was thoracic. Thoracic pump is, see, your thorax is a pump. You should first understand this. Your thorax is a pump. What is the function of pump? From one side it brings things, from other side it gives things. That is the concept which we understand from the heart physiology. From one side you are getting venous return, and from other side you are putting the stroke volume. Now I am telling you, in the thorax, what happens once you inspire? See, listen to me, guys. Listen to me. See, I will bring microphone close to me. See, sitting normal first. Okay, sitting normal. Now, what happened? You increased your, what you did? You increased the negative pressure in your chest. You sucked everything. See, you are doing a suction pressure. Your lungs are suction. See, once you do inspiration, what happens is you create a negative pressure in your chest, more negative than the atmospheric pressure. That's what is the meaning of negative pressure. You are making it more negative, that is going more away from the atmospheric point. Okay, so you're saying, okay, you did it. Now I'm holding it. What happened? Your intrathoracic pressure became more negative. In the intrathoracic pressure becoming more negative, what happened? You expanded your thoracic cage. Once you expanded your thoracic cage, what happens? This pressure is also going towards the great veins. Your CVP falls, your central venous. Think like this. Think like this. Think like this. This is your full central vein. I represent your body like this. This is your body, and this is your full central vein. Finally, I take every vein and collect them. I collect them in your center. I collect them in the center. Okay, I collect them in the center and I describe them as one vein. Okay, everything is coming into the right atrium. This is your central vein. What will happen once you are expanding your chest? What will happen? Will the pressure decrease inside or increase? It will decrease. The pressure will decrease because you have expanded the chest. You are giving more, you are increasing its lumen, isn't it? The lumen is in other way getting increased. So what will happen? Your venous pressure, this decrease in the venous pressure will bring more blood. I am giving more space. When I am decreasing the pressure, what will happen is I am sucking more blood towards the chest. I am sucking more blood towards the chest. That means I am increasing, I am facilitating, I am helping the venous return to come to the heart. I am facilitating the venous blood to come into the heart. That is the concept you have to remember. So in skeletal muscle pump, we said the muscles are actually the heroes, but in thoracic pump, who is the hero? Negative intrathoracic pressure being done by what? Inspiration. What does it do? Increases the venous return. How? Because it decreases the pressure on the central vein. Are we clear with this? So I hope you have enjoyed this discussion. We will continue from here tomorrow. So the purpose of these long videos is just to help you understand so that we can build the concepts more stronger. Okay. So see you all tomorrow. Take care. Enjoy. Maybe. Bye bye.